Marcela Espinoza, and I'm going to present Dynamic Measurable Residual Disease Kinetics Defined Conditional Transplantation Benefit in Acute Lymphoblastic Leukemia, a ALL.GRELAL Chile real-world study. As introduction, we can say that measurable residual disease is the most powerful prognostic biomarker in adult acute lymphoblastic leukemia. However, whether transplantation benefits is biologically conditioned by MRD kinetics rather than static MRD measurements remains incompletely defined, particularly in a real-world adult populations treated outside prospective trials. The aim of our study was to evaluate the prognostic impact of MRD kinetics and the conditional benefit of transplantation in a large real-world cohort of adults with ALL. Regarding our methods, we have 160 adults that received transplant across 15 centers. The median follow-up was 36 months, and all centers obtained the approval from their respective ethics committees. We define MRD as less than 0.01% by flow cytometry and assesses after induction and prior to transplantation. We use formal interaction testing, landmark analysis, and dynamic trajectory modeling to evaluate the relationship between MRD and allogeneic stem cell transplantation in first complete remission or CR2 and survival outcomes. Regarding the results, in the first table we see the characteristics of the diagnosis of the patients. Lower we see the molecular assessment. That is remarkable that 33% of the patients has BCR-ABL1 positive and complex karyotype in 12% of the patients. The immunophenotype shows that the most of the patients was BALL with 82% of the patients and myeloid markers in 27% of the patients. Next to that, we have characteristics of the transplant, and the regimen used to achieve CR was new drugs in 21% of patients and other drugs in 78%. The MRD post-induction was 51% in negative and 48% positive. The conditioning used mostly was myeloablative conditioning in 79%. In the MRD status pre-transplant was negative in 83% of the patients and positive in 12%. There's other characteristics like immunosuppression and neutrophils and platelet engraftment. And also in the other table we have the outcomes. Now we see that relapse incidence was 31%, the non-relapse mortality 6.2%, acute GVHD 25%, and also in the graphics we see that the median overall survival was 132 months, the median PFS was 89.8 months. In the graphic of the middle we see when we divide the patients between first complete remissions and second complete remissions, the outcomes were different between OS and PFS. And in the lower graphic, we see in the black line the patient who has sustained MRD, which is that negative after the induction and negative before the transplant. And in the red line, the patients who have sustained positive MRD. We also see the blue line where we see the patients in an intermediate level who are the patients who converted to positive to negative MRD before the transplant. The univariate analysis showed the high creatinine diagnosis, positive MRD post-transplant, and positive MRD post-induction, also BOD post-transplant has a higher hazard ratio. And in the forest plot, we see the multivariate analysis when we see also high creatinine diagnosis, BOD post-transplant, were significantly different with a higher hazard ratio for OS and PFS. Finally, the conclusions, we can say that MRD genetics dictates survival. Persistent molecular disease post-induction seems to be an independent predictor of inferior survival, transcending baseline risk factors like age and genotypes. Transplant benefit is MRD dependent. Allo stem cell transplantation in CR1 is optimized when aligned with molecular remission, and persistent MRD reflects resistant clones that evade the GBL effects, Shift to dynamic decision making. Consolidation and transplant strategies could be guided by dynamic MRD trajectory rather than a static baseline risk profile. And the future directions, despite retrospective limitations, the data support a new paradigm incorporating dynamic MRD-guided transplantation timing into future prospective trials. MRD-guided transplantation timing into future prospective trials. Resistant clones that evade GVL effects. Shift to dynamic decision making. Consolidation and transplant strategies could be guided by dynamic MRD trajectory rather than static baseline risk profile. Future directions, despite retrospective limitations, the data support a new paradigm incorporating dynamic MRD guided transplantation timing into future prospective trials.